I'm Paul Stelzer. I'm a cardiac surgeon at Mount Sinai Medical Center in New York. I've been practicing heart surgery now for 32 years, and I've done 6,000 open heart operations. At least 4,000 of those are valve related. That's been my first love, is valve surgery. Originally, when I came to medical school, I knew I wanted to be a surgeon. I've always liked to do things with my hands, whether it was building with an erector set or making puzzles or whatever. So I knew medicine, it was going to be surgery.
Hi, my name is Peter Woglom. I'm 39 years old and I live in Brooklyn, New York. I was diagnosed when I was 9 with rheumatic heart disease. In recent years, my heart began to dilate because of the aortic valve issues, and that's why it was time to remediate the problem.
The aortic valve has really been my focus, and within that there are lots of different things you can do to repair, to replace the aortic valve. I've done about 530 Ross operations.
Well, it was my cardiologist's initial recommendation that I undergo the Ross procedure with Dr. Stelzer, but as I started to do my own diligence as to what my surgical options were, I considered bioprosthetic valves, also considered mechanical valve.
So the Ross operation was named after Donald Ross, who took his patient's own pulmonary valve, living pulmonary valve, and transferred that to the aortic position to make a new aortic valve out of it. Then he put a donor valve where that came from, a homograft valve. That's the Ross concept. The Ross procedure has a number of specific advantages. One is it's the only one that gives you a living aortic valve. And living things do things that dead things don't. They talk to other cells, they talk to other structures in the heart, and they provide blood flow that's just unsurpassed by any of the artificial ways we've reconstructed valves from other materials.
I knew from the get-go that the mechanical valve just wasn't for me. The idea of taking Coumadin for the rest of my life and some of the other issues that came along with the mechanical valve just wasn't the choice for me. In terms of the bioprosthetic approach, I was somewhat nervous about the fact that they only lasted a certain number of years and I'd have to do other procedures down the road.
The durability of animal tissue valves is getting better, but it's also poorer in younger people than it is in older people. So you got a patient who doesn't want to take blood thinners, so he doesn't want to have a mechanical valve, and you have somebody that you want to have the durability that would be greater than what you could get out of an animal tissue valve. Those are the patients that I say, okay, we should put Ross at the top of the list.
I found the argument for the Ross procedure, especially one done by Dr. Stelzer, to be the most compelling option I had. Dr. Stelzer is the most sort of accessible surgeon, let alone doctor, I think I've ever met. The amount of time that he made for me to answer my questions when I would shoot him emails in the middle of the night or at certain points during the weekend was just unbelievable.
Well, my best advice for somebody who's considering a Ross operation is to think about why. And it's almost always related to not taking blood thinners, not having to have your life revolve around blood tests and blood medicines and so forth, but to be medicine-free and restriction-free.
My surgery took place on February 11th, so I'm coming up on 3 months now. So far, I'd gauge it as a success, but I guess only time will tell, but it seems like I'm on the right path so far.
What do you want to do in life? And how young are you? And do you have a life expectancy that's at least 25 years? Then the Ross is my best advice for that patient. There are a lot of other alternatives, but it's at top of my menu.